Welcome to the Business of Healthcare, a twice-monthly podcast from the Center for Healthcare Leadership and Management. The center is based at the Naveen Jindal School of Management at the University of Texas at Dallas. The show, like the center, brings together business leaders and other forward thinkers to discuss how best to meet the challenges of a rapidly changing, increasingly complex healthcare system. I'm your host, Dr. Keith Thurgood. Today's guest is Dr. John McCracken. Dr. McCracken leads the Alliance for Physician Leadership, and in his program, he teaches the physicians the skills and competencies they need to be successful in operating in this very complex healthcare world that we live in. And today's subject is very appropriate. The title of it is, What's the Future of Healthcare? So, Dr. McCracken, tell us a little bit first about your program and what you think about the future of healthcare.
Well, thank you, Keith. I've been involved in healthcare for about 25 years. 5 years of it was in workout and turnaround management of distressed physician organizations. And for the last 20 years, as you noted, I've been the director of our graduate business program for physicians. So in that time, really, I've gotten the perspective of physicians, and that's the perspective kind of I bring to this subject of the future of healthcare.
So when you think about the future of healthcare, many would say that the current healthcare market is unsettled, it's chaotic, we don't know what's really going to happen in the future. So what do you think some of the root causes of that are?
Well, the real root cause is inflation. For the last 50 years, healthcare costs have grown faster than the national economy. Today, healthcare spending will be about $3.8 trillion in 2018. Now, that's bigger than the whole national economies of all but 4 other countries in the world. Healthcare inflation is unsustainable. The average expenditure in 2018 will be over $11,000 per capita for the 330 million people in this country. Again, that's an unsustainable cost. The real driver of healthcare inflation for the last 50 years has been fee-for-service, fee-for-volume. Physicians and other providers have been paid based upon the number of services that they provide. And that has resulted in very intense medical utilization in this country, and as a consequence, very high costs. What's happened really since about 2010 is that payers, both federal government as well as employers, have been driving toward a new payment system away from fee-for-service towards something called value-based payments.
Well, you brought up a really good point. So we're spending almost $4 trillion a year in healthcare. That's a massively big number, $11,000 per capita in the United States. And as you rightly said, it's totally unsustainable. And as we think about this value-based payment system that you just started to touch on, how's that going to work? And do you really think it's going to be successful in the future?
Well, if you take a look at the past, fee-for-service, once again, pay for volume, physicians and other providers have been organized around practice discipline. The value-based payment model is really based upon managing the health of populations, and that requires physicians to reorganize the medical service delivery model away from organizing around their practice discipline to organizing around the patient or disease state. What we've had for the last 50 years is really a craft model of healthcare delivery. Once again, with the individual physician organized around their practice discipline, providing a customized care for the individual patients that present. With a population health model, or the value-based model, physicians and other providers, including hospitals, are being paid to manage the health of a defined population of people. Once again, this requires a very fundamental reorganization of the medical delivery model. And physicians are very resistant to this, moving away from their customized or customary practice of organizing around their practice specialty to organizing around a patient or disease state requires a fundamental change in the way they practice medicine. And they are proving very resistant to that model.
Yeah, I recently read a statistic that you might be able to comment on, and it basically said that about 67% of all physicians in the United States that are high Medicare practices think that this new transition, moving from fee for service to fee for value, where we're paying for better incentive, better performance, etc., will actually end their independence. So, how does that play into this idea that we need to change the business model, moving from a craft based model to something that's more population centered?
Well, the transition to population health has a couple of implications for providers. One is it shifts more risk, more financial risk to the providers. That's again something that they're resisting. The second is that physicians are being asked to trade essentially autonomy for influence. In the old fee for service model, physicians were autonomous, they were captains of the ship. They could decide whatever intervention that their individual patient required and then provide it. In this new model of population health, they're members of a team. They're actually becoming team leaders, where they and other members of the care team have to agree upon a particular clinical protocol or pathway that they will use to treat the population of patients for which they're responsible. This is a transition from autonomy to influence. And once again, that's one of the reasons why physicians have been somewhat resistant to this.
So, that's a really great point, Dr. McCracken. So, in the old world, our physicians acted as basically independent contractors, as you just described. But in the new world, this complex, adaptive world that we're moving into, where we transition to this fee for value, it's really about influence and about developing a skill set and competency that is more collaborative and team based in nature. And that's hard for physicians, as you mentioned.
It's very difficult, partially because of their training. The medical schools, the roughly 126 medical schools in the United States, still really are teaching physicians based upon the old model of the individual practice specialization. They really are very much the last ones to the party at moving toward collaborative team-based care. So physicians coming out of medical school and out of residency are really trained on the old model. It's only when they step into these new value-based payment systems that are principally in the private sector that they are really faced with this reorganization of the service delivery model.
And I think that's one reason why the program that you're offering is so critical, because you're teaching these physicians that in the new world, they have to be more adaptive, they have to be more collaborative in order to provide the services and achieve the financial and clinical outcomes that the new payment system will demand.
I think that's absolutely true. But once again, this runs counter to their initial training, where they are trained really as captains of the ship, as autonomous agents with independent decision-making authority. So again, they've got to cross that divide. The younger ones are more receptive to that. There's a big difference between the younger generation of physicians and the older. The older generation of physicians, those say 50, 55 and older, are quite resistant to this model. They're very resistant to this movement. The younger ones are a little bit more accepting.
Well, so at the end of the day, do you really think that this value based payment system will be successful, given what we've just described?
Um, there's a couple of things that, uh, if it played out, if we have, let's call it a soft landing, if this played out over time, my guess is it would take between 10 and 15 years before this new medical delivery model really gains traction. Some estimates will place it out at 20 years and some as short as 7 or 8 years, but most observers say 10 to 15 years. The question is, do we have that long? One of the things that could happen, in fact, often does happen, is that something comes out of left field to disrupt a major social system. For example, healthcare costs roughly are 30% of the total federal budget. It's the largest item in the federal budget. Another financial crisis, a recession, and one is long overdue, would drive the federal deficit to over $2 trillion. When that happens, and I believe $2 trillion to be kind of a magic number on top of a $19 trillion existing debt, Congress could act precipitously. And the big bullseye, of course, is healthcare spending. As I said, it's 30% of the national budget. So whatever happens there at the federal level will certainly have major impacts on the national economy. Also, a recession would create a lot of problems in the states. Medicaid is the largest expenditure for most state budgets, and a 1% decline in gross national product during a recession generally generates a 2% decline in state tax receipts. In other words, the impact on the state tax receipts is double the decline in the national economy. That will have also a very significant effect on Medicaid, which again provides service to over 55 million people in this country. So a financial crisis, a recession, would have a financial ripple effect that would be very impactful on healthcare. Just as a sidebar, no significance, but it's interesting that every Republican president since Ulysses S. Grant has experienced a recession in their first term.
Well, that's not a pretty picture. So it comes back to the very first question that we asked. So you said early on that inflation is our number one issue in healthcare. We've got to get the cost down. And when we spend 30% of our budget on healthcare related items, it consumes 18%, or represents 18% of our GDP. We absolutely have to do something. So I think it really underscores the importance of moving to something different than we have today. This idea of moving from fee for service to fee for value. What about innovation? Can innovation help drive out cost in the healthcare system?
It certainly can. There's a lot of innovation around the edges in healthcare. There's a lot of small companies that are developing. They're developing very creative solutions in the area of genomics, in new methods of healthcare delivery, the growth of the retail clinics and urgent care clinics. As I said, there's a lot of entrepreneurship, much of it around apps. Virtual healthcare, of course, is something for the future, is really beginning to develop. Telemedicine is coming to the fore now. Also, some very large companies are getting involved. As you know, CVS and Aetna are in the process of a merger. Actually, it's an acquisition of Aetna by CVS of $66 billion. It was just recently approved by the shareholders of Aetna. I believe that CVS has eyes on managing chronic care costs at the pharmacy window. Now, that's going to take several years for that strategy to play out. As you also know, Berkshire Hathaway, Amazon, and J.P. Morgan have announced a joint venture to involve themselves in healthcare, in managing healthcare costs. Nobody yet knows what their intentions are. I don't know if even they know what they're going to do yet, but they're going to take action. Apple has just developed the AC Wellness approach. Actually, it is an experiment in managing their own employees' healthcare costs, but if successful, I'm sure that model is going to be rolled out to employers across the country. So there's a lot of experimentation going on. I believe you're right with your initial premise that we're going to move toward value-based care in some form or fashion. The question is it going to be a soft landing or a hard landing? Is it going to play out over time as physicians adjust to this new medical delivery model and experimentation continues to move patients from an inpatient setting to an outpatient and ultimately to a virtual setting? Or is it going to be precipitated by some kind of national recession or financial crisis that causes some kind of immediate reaction on the part of Congress, state governments, and the financial markets? That's the real question.
And it's a big question. And if we had a crystal ball, I guess we could figure that out. I think at the end of the day, it really highlights the importance of aligning clinical and financial outcomes in the healthcare system And when I think about innovation, I'm also reminded how important it is that we as individuals have a very important role to play in our own healthcare. So, this whole idea, for example, of personalization of medicine, this personalization revolution, it's estimated that about 70% of our healthcare, a person's healthcare, is driven by either environmental or lifestyle factors. So, we as individuals can help drive the costs down by doing things differently than we're doing today. If you think about CVS and Aetna, all of these other players that are now coming into the healthcare space, I think they're going to drive some disruptive innovation that will force us and force the healthcare system to think differently and drive better outcomes and better health outcomes and better financial outcomes at the end of the day. You'd mentioned telemedicine and AI. I think telemedicine is another interesting avenue that is probably worth exploring at some point in the future. The whole idea of moving from inpatient to outpatient to a virtual setting, I think has lots of merit. Do you agree with that?
I do, and I think certainly that's the way it's going. It began a few years ago as we began to move patients from the inpatient, very intense care setting of a hospital to the outpatient, to the physician's office, then to retail and urgent clinics, and then ultimately into the virtual space with apps and telemedicine and others. But there's another side to the coin, and that is in this value based payment population health management model. The health of a population is only 20-25% dependent upon medical care. The other 70% is really dependent upon socioeconomic factors and lifestyle choices. Those are things over which physicians have no control. So they're being paid to manage the health of a population, but the service that they deliver, medical care, is responsible for probably only 25 to 30% of the outcome. That is one of the logical contradictions in this whole value-based payment model. Now, to believe that people are going to take more control over their health, that's a good thought, and hopefully it'll happen. But remember, socioeconomic factors, nutrition, income, education, the growing income inequality in this country, these are all factors that affect the overall health of the population. So I don't hold out much hope that people are going to, at least in any short period of time, be able to take control of their health and change their behavior. It's something that's happening at the edge, but I don't believe that it's going to be a big factor in ultimately how equilibrium in the healthcare market is ultimately established. It will be established. It could be established as a single-payer system. That certainly is going to be in play in the 2020 election. So frustration on the part of the public, and that is pretty significant at the present time, could lead to a very different model.
Well, that's a great point. So, you just mentioned something that's very important right now in the United States in terms of discussing the models of the future. You mentioned the single payer system. So, do you believe that's still alive? Do you think it's still a viable option?
It's very much a political option. Once again, I believe that that's very much going to be in play in the 2020 election. As a matter of fact, in a recent poll, a majority, a slim majority, but a majority nonetheless, of physicians favored a single-payer model. The problem is, as I said, that healthcare is presently 30% of the federal budget, and we're going to have a federal deficit this year of close to $800 billion. If you went to a single-payer system, a true single-payer system, it would require a major increase in taxation, a big increase in taxes. Whether the American public would be able to tolerate that or would accept it, I don't know. Oftentimes, people will vote benefits without consideration of what their cost is and what they're going to have to do in order to pay those costs. I can tell you that those people that are advocating a single-payer system are advocating its benefits without really reference to how we're going to pay for it.
Well, there's no free trucks, there's no free cake, there's no free healthcare anywhere. Somebody has to pay for it. And I think as we think about what this might look like into the future, we think about a single payer system and whether that will actually come to pass or not. It's clearly something that's gaining momentum, may not be the right word, but there's a lot of talk about it. It will certainly come up in the 2020 elections. And I guess we'll see how it goes and how all this plays out and how we actually start to align a single payer system with this idea of driving out cost and fee for value at the end of the day. So, one last question, Dr. McCracken. How long do you think it will take for the healthcare market to return to any type of equilibrium? You mentioned it may be a decade or two before things settle down. You'd mentioned the idea of whether it's going to be a hard stop or a soft stop. What are your thoughts on that? Do you see us getting to a point of equilibrium anytime soon?
Well, my hope is that I live long enough to see it from the nursing home front porch.
You're getting old, though. I don't know if you can make that.
Let me make a point first. Who pays for health care? Workers and households pay for it all. To the extent it's financed by government, workers and households pay for it in terms of higher taxes and a greater debt burden on their children. To the extent employers finance it, workers and households pay for it in the form of lower wages and lower employment. The American public has yet to accept the notion that all health care is ultimately paid for by workers and healthcare and households. The belief is that you can shift the burden to someone else. I believe that the healthcare market is not going to return to equilibrium until people begin to accept the fact that, as you pointed out, there is no free lunch, and that workers and households are going to pay the entire burden, regardless of who fronts the financial costs, government, employers, or out of pocket. Are we going to come around to that? And what will cause us to come around to that? Looking at history, great social change has generally been precipitated by some sort of major event or crisis. I suspect that might be the case in the form of some kind of recession or financial crisis. They come back every now and then. I worked on Wall Street in the 1980s, and I can tell you there that I remember the time when the Treasury bill rate was 12% and mortgages were 16%. Those days are not gone forever. Nothing is forever, and the current regime of low interest rates and relative stability is ultimately going to be punctuated by periods of financial crisis and recession. And the impact of those is going to be on the healthcare market. So I suspect equilibrium may come well before 15 or 20 years, but it would come necessarily with a hard landing.
Well, as the economist Stein said, if something cannot go on forever, it will stop. We don't know when. Now, Dr. McCracken, I was attending one of your lectures one time, and you had a great quote about theory and practice. Do you remember that quote?
Let's see. Let me think about it. Theory explains everything when nothing works, and practice explains nothing when everything works.
And in healthcare, we have a combination of both.
Nothing works, and
nobody knows why.
And nobody knows why.
All right. Thank you, Dr. McCracken.
Okay.
Thanks for joining us here on the Business of Healthcare podcast. Join us online at businessofhealthcarepodcast.com to find more episodes, episode notes, links, and more. Be sure to subscribe to the Business of Healthcare podcast on Apple Podcast or your favorite podcasting app. To learn more about the Center for Healthcare Leadership and Management, go to jindal.utdallas.edu and then search under the Centers and Institutes tab on the navigation menu. I'm Dr. Keith Thurgood, Director of the Executive MS degree in Healthcare Leadership and Management at the University of Texas at Dallas, where we're leading change by changing how we lead.